guys hear me okay? I'm pretty loud typically. Yes, thank you guys for being here. I appreciate it. I know that we have not had the formal ability to sit down together and discuss some good things that the department is doing. Been slow news for us recently, right? So I am really honored to have this position. As Kelsey said, I was appointed earlier this year. I was appointed, I believe it was January 18th or around there, and then started in my official capacity in February 22nd. So after finishing my time with my previous organization, so that's just over 7 months. I did the calculation this morning, and that's really not a ton of time, but I realized that there is some angst and maybe some frustration around some stakeholders that want to know what we're up to, which I know is well intended, and I'm happy to provide some of those updates today. I do want to start with acknowledging some of the challenges that we've experienced and some of what we came into with our new leadership team. So I started February 22nd, like I said, but the day I was appointed, so before that, I was made aware of a concern that we had with a previous leader of our organization. As soon as I received objective evidence of that concern, we escalated it to our Inspector General, our internal investigators, and so they started that investigation. And then as soon as there was potential criminal activity, that was handed off to law enforcement. So that was day one. Day two, on a personal level, I found out my mom was diagnosed with cancer. So that was a tough blow, as you can imagine, trying to wrap your head around this massive life shift in your career. Don't have cancer that runs in my family anywhere. She is someone that has run circles around me at our workout classes for my entire life, and she's always been in much better shape than I have been. By the glory of God, she's cancer-free right now. After a lot of chemotherapy and a lot of resilience. So that was a curveball to adjust and exercise my own mental health and resilience as I was trying to navigate through this new sphere that I came into. So some of you may have also heard there was a class action suit that I came into, the Briggs case, which has been eventful over the last few weeks. So learned about that as well. And quickly met with the Attorney General to get up to speed on that and figure out what we needed to do to move forward in a meaningful way. Also, I learned of a federal investigation from the Department of Justice that we were in the middle of. That is not specifically to our department, that is Oklahoma as a whole, specifically Oklahoma County, but we were one of the primary stakeholders that they were looking at. Also, we had a little thing called Medicaid Managed Care that went live in April after I started. So that is impactful to not only our state operated facilities, but all of our partners, our CCBHCs. We contract with approximately 600 different providers across the state. So we were trying to be as resourceful and helpful through that process in partnership with the Healthcare Authority as we possibly could be. Thankfully, we have brilliant people here that were able to assist in helping our providers through that process, and we're still not there, but we'll get there. We also have been trying to reevaluate and revisit our relationships and partnerships across the community. And the partnership component is a really valuable thing for me. And frankly, that's part of what piqued my interest in this job in the first place, was observing those silos or that wall between the public sector and the private sector. I think we all are acutely aware of the enormity of the behavioral health crisis that we're in as it stands and as it has been. And also the enormous task of preventing us from getting back into this place when, say, my 3-year-old is a teenager, right? We know we need to do better for the future generations of Oklahoma. So we cannot do this independently. The private sector can't do it independently. The public sector can't do it independently. And Oklahoma has a lot going for it in terms of access points across the care continuum. So part of what you'll hear a little bit about later is how we want to be the thread between all the pieces of that mental health system. So we spent an enormous amount of time trying to rebuild relationships with university partners. We have an abundance of residencies across our system between the University of Oklahoma and between Oklahoma State University. So really trying to understand who those key partners in the community are. Again, not just our CCBHCs, but certainly an enormous partner, but our advocacy groups. We have our legislative body, our executive branch. There's a lot of stakeholders to make sure we are all rowing in the same direction and on the same page. The vending machines also have been quite a debacle. I know that there's some in the organization that said, I don't want to hear anything else about vending machines, and I empathize with that. But the fact of the matter is, and this is important, is that the vending machine strategy is excellent. It makes a lot of sense. It is a SAMHSA endorsed intervention that is an effective way to distribute Narcan and fentanyl test strips into the communities. This was also discussed before I officially started, trying to figure out where we were with the vending machine strategy and how we could kind of put the best fix on it possible. So as we navigated through that decision, I learned about the history of the vending machines. It started as a prevention initiative, and it was quickly morphed into a marketing and communication strategy. It certainly should have been a partnership between those two divisions. However, with it being a primarily communication strategy, it deviated from the intended implementation plan that SAMHSA would recommend. So with that deviation, it took us away from the data that would allow us to understand the impact of the program. Instead of it being driven by the prevention team that would have done it in a very graded implementation, looking at our highest counties of overdose incidents and placing a machine in a meaningful location and tracking the appropriate data points to make sure people are getting it when they need it, we didn't have any of those data points. Instead, it was prioritized as a marketing initiative. So again, both of those teams should have been at the table, but instead of it being a partnership, it turned into more just a marketing focus. So because of not having access to the data on the outcomes of that intervention or of that initiative, we did not have the rationale to continue investing in that initiative. So it's not to negate the initiative itself. Again, it can be done, and some states are doing it very well. And if the funding is there and the data is there, the need is there, it's something we might consider again in the future. And please hear me on this, that pulling the vending machines does not mean that we have pulled Narcan and fentanyl test strips. Before vending machines were ever launched, we had exceeded our SAMHSA set saturation requirement. So that means based off of population, based off of need, all kinds of fancy data that SAMHSA looks at, they determine how much of those reduction strategies need to be in the community. We had exceeded that percentage, that amount, and this was supposed to be a pilot to see, could we do it differently? So we have approximately 17 different partnerships across the state in which we distribute Narcan and fentanyl test strips. Those will continue. OMES is working right now to sell the vending machines. We hope they stay in Oklahoma. We'll do everything we can to make sure they stay in this great state. And we've already had people reaching out to see from hospitals, from tribal communities saying, can we get the vending machines? And we're directing them to OMES. We're happy to partner with them, continuing to provide Narcan and fentanyl test strip stock if they need help with that. And also we'll continue our mail-in program, which is our largest distribution point for Narcan and fentanyl test strips. So that is not going away, and we would never envision threatening something, access to something like that, that has the potential to save lives. Was that enough on vending machines? Okay, we can keep going. Okay, so last few things, and then we'll get to the fun stuff. This change to the organization is more enormous than I could have ever anticipated. It has been since 1999 that this organization had a commissioner or a leader from an external organization. That's a very long time. I'm a different kind of leader anyways than historically this organization has seen, at least to my knowledge. And having me come from an external organization makes it that much more challenging to implement change and to transform the system in the way that it needs to be transformed. Let me be clear, when I say transformation, that does not mean that everything needs to change. There is so much good that happens in this organization, and I have had the chance now to see a lot of that firsthand. When we talk about transformation and quality and agility and all of those things, that's being a good leader in a healthcare organization. That's being cognizant of what the evidence says we need to be paying attention to. That means we're paying attention to the changing needs of our community, and we're paying attention to the new partners in the community. So we should always be transforming and changing our practices and setting new standards and expectations for ourselves. So I can only imagine being on the other side of this coin and having someone come in from another organization and say, we're changing up everything. That can't feel great, but we're not changing up everything because there's a lot that works. We are looking aggressively at pieces of the organization that have not been investigated what seems like for quite a while. When we look into those corners that seem to have been dark for a while, we're finding some concerning things. Some of those things you all have helped us find. We are intending and will live up to leading with integrity and transparency. That's the name of the game. And I've made it very clear in our leadership summit and in other conversations, if that's not your cup of tea, I wish you well. But we will be leading with transparency and integrity. So we are confident that we will continue to find corners that we didn't even know we had. And we will continue to find broken processes concerning initiatives, whatever the problem might be. We will continue to find more problems. And I'm glad that we will, not for my own mental health, but for the sustainability of a system that will work moving forward. If we do not find the problems, we can't fix them in a durable and sustainable way. So it has been very unusual, even for our senior leadership team, for me to ask, show me what's not working. Show me where we have opportunity to improve. It's very clear to me that previous administration, the long line of previous administration, which I have immense respect for, because newsflash, this job is very hard. Lawsuits aside, this job is very, very hard. So I have immense respect for everyone that came before me in this role. We are looking at how we can bring to the surface the problems because we are prioritizing outcomes over the appearance of what this organization does. We are not here to be flashy, to be sexy, to be cool. Some of us happen to be those things. We are here to provide outcomes to Oklahomans, period. That will always be our true north. There's a lot of noise that will try to get in our way and certainly has in the last 7 months, but we will not change the reason that we're here. So when I say that we will continue finding dark corners and we'll continue finding problems that we need to address, hopefully collaboratively, my ask of those in this room and those that aren't physically present with us, but virtually, that you partner with us in helping us understand what those problems are. Because I'm new to this world of state government and politics and whatever label we want to put on this. But I'm confident that we're all here for the same reason, which is to make life better in Oklahoma. So it doesn't matter who you are, what your affiliation has been with mental health or substance use disorders, but I guarantee every single person has been impacted in some way, and every single person has identified at least one way that the system can be better. So please allow us some grace and partnership as we try to figure out what's not working and simultaneously try to implement or grow things that are working. All right, we get to the fun stuff now? Okay, perfect. All right. So I think the context and of course, the list could go on, but they would turn more into a support group and we don't need, maybe next time we can do that. The challenges that we've been faced with the last 7 months or so have highlighted and really magnified the importance of our mission as an organization. And I hope that after learning a little bit more about what we've been going through, that resonates with you as well. So our mission as an organization is that we are dedicated to excellence in behavioral health services. And excellence is not just a cute LinkedIn buzzword. We have had some pretty impactful conversations about what excellence looks like across our different teams in the organization. To me, excellence is having confidence in any department, division, facility, partner that you interact with within our organization that I feel confident enough that I would send any of my family or friends or loved ones to that service, whether that's a partnership with our prevention team or school-based intervention services, that I would be proud that my kid could be on the receiving end of the school-based intervention that we provide or training that we provide, or simultaneously that I would feel confident sending one of my family members to one of our state-operated facilities, because I know the bar is set at excellence and nothing less. So there was so much meaningful feedback around excellence being consistent, being honest, being filled with integrity, knowing what you're going to get every single day from your coworkers, from your patient care, from your boss. There's so much that goes into it. So I am thrilled that we landed there. Our vision as an organization is that we, as Oklahoma, are going to set the standard for behavioral health systems that provide transformative, agile, and quality care. So those words you've heard me say a handful of times already, and transformative means that we are keeping up with what the evidence base tells us we need to do. It means that we are being flexible in meeting people where they need to be met through digital interventions, through different modalities that have been proven effective by the evidence. That means that we are able to be nimble and to adjust to what Oklahomans need, no matter what that need is. Because we're the safety net of Oklahoma. That's a big, big responsibility. And we can do better by filling those shoes, by being more consistent, and by having the highest quality of care possible. There was a reason that we brought on a Deputy Commissioner of Safety and Quality, because we take it that seriously. We are working on building out a system-wide infrastructure that will allow us to manage safety events in real time, will allow a just culture to where employees, clinicians, physicians, leaders feel safe and confident in escalating safety events that occur. In just 6 months in 2024, from January 1 to June 15th, we had 1,044 incidents of our employees being injured by assaultive behavior. Coming from a very large health system with 9 facilities and how many, 11,000 employees, we didn't sniff that. There is no world in which I can tolerate 1,044 assaults on employees in a healthcare setting. This has been tolerated, purposefully or otherwise, and we're not doing that anymore. Day 2 of our leadership summit was Safety Day. That doesn't just mean how do we keep our patients safe? That's why we're all here. How do we keep them safe? How do we get them well? But we can't do our job as the Department of Mental Health and Substance Abuse Services if we feel unsafe. If I'm a mental health tech, if I'm an administrative assistant, if I'm a physician, if I'm housekeeping, doesn't matter. You should feel safe in the workplace that you show up to. We are on this weird trajectory in healthcare in general where it's been tolerated for employees and healthcare providers to be assaulted. So what we are trying to do is change that narrative, change that culture, which will take time, as all of this does. But we are equipping our staff with the tools they need to be successful. We are equipping them with training that goes beyond the standard package of mental health training so that they feel empowered and confident when they enter into these high-risk situations, which we've got news for all of you if you don't know, that's most situations in the mental health field can escalate very quickly, and most do. So we have to have confidence that our employees feel safe, well-trained, and educated to take on any situation that comes their way, and that does not mean fight. It does not mean fight. That means know what options are available to you and get yourself out of harm's way. Patient care always comes first, but we will not have any employees, clinicians, or physicians left if we continue to let them be treated this way. So you will see a lot of initiatives around safety, again, of those that we serve and our community as a whole, and certainly on our workforce. So we have next our pillars. We have 5 pillars. Some of you may be familiar with this concept. They're purposely called pillars because they should not change. If one changes, then there better be a pretty good reason why. They are supposed to be the foundation of our organization and which our structure as an agency stands. So every interaction, every touch with a patient, every phone call, every time Liz greets you at the front and welcomes you here should always be viewed through these 5 pillars. The first is high reliability and trust. I think you can already identify within the things we've discussed so far that we are aggressively working to become a highly reliable and trusted organization. That comes from not only what happens in our patient care spaces, but what happens in our community relationships, being a valuable partner, being consistent, following through on what we say we're going to do, and to have very purposeful strategic initiatives and metrics so we can quantify what success looks like. As a field in behavioral health, we really don't do a good job of measuring success with specific metrics. So we are purposefully laying groundwork. A lot of what you'll see probably in 6 to 12 months, probably 12 months, is establishing baseline, right? Because we can't know exactly where we need to go if we don't know where we started. So I realize that that's kind of lackluster and not exciting, but we have to have a strong baseline before we can make any meaningful progress. Innovation and evidence-based care also shouldn't be a surprise. You've heard me mention a few things already about innovation and evidence-based care. We should be a leader and setting the standard for what evidence-based care looks like. We have our Chief Medical Officer, Dr. Jason Beeman. I just came from a meeting in Tulsa with him actually, talking about how we can set the standard for specific practices, not just how do we fix our internal organization, but how do we partner with managed care entities, with universities to set new best practice standards for, say, overprescribing of antipsychotics, right? There are things that our physicians have access to in our strong physician community that can help guide our specific challenges that come up over time. We then have coordination and collaboration. Also, I really done a nice job teeing these up for you. Coordination and collaboration. This one is a lot harder than it should be. And again, this is part of what piqued my interest in taking this job is we've all got to show up to the table. And whether people like when I show up to the table or not, that's up to them. But I will always show up to the table and be honest and set my ego aside. One of the first questions I got in this job was, what's next for you? And frankly, the first few times I was like, what am I talking? What does that mean? And I kept getting the question and it started to make sense that, oh, okay. This is a new thing. The way that I've come in, our leadership team has come in as a new thing. It's different. Maybe not new, just different. And it's unusual to not have something else that we're working toward. I almost didn't take the job because I couldn't see what's next. At least when you're in a large corporation, you can kind of see something that's next. So I want to be very clear. I'm not here for me. If I were here for me, I would have been gone 6 months and 29 days ago. I am here for the humans of Oklahoma that deserve so much better and what we can do in our mental health system. Stewardship and alignment. One of our specific strategies is around financial optimization so that we have confidence in every single dollar and where it is going, and that is it is designated specifically in alignment with one of our already identified goals. We have such compassion in our field and we want to fix every single problem because the fact is that there's not anything that comes to us that's unimportant. But we have to prioritize what we will focus on or we will never get anywhere. So in order for us to understand where those dollars are going, that means that we will have to be more purposeful in our spending. We're already working on optimizing our contracting processes so we have clarity as to what the expected outcomes are of our contracted partners. And we have confidence in our internal process that we have the checks and balances in place to hold those accountable that we partner with and to hold ourselves accountable. Last pillar is data and analytics. Also shouldn't be surprising. The beautiful thing about data is no matter who's at the table with you or who's angry with you, data is pretty hard to argue with as long as it's validated, right? Data takes the emotion out of everything and it makes the decision-making pretty easy. Because if we have accurate data and information we're working with internally, externally, then we know where we need to go. And part of that is knowing where we have opportunity to improve. So you will see nothing but brutal honesty from us, as much as Christina will let me be brutally honest. And you will see transparency, you will see partnership, you will see an enormous focus on quality and safety and partnerships. We're looking specifically at data sharing agreements where it makes sense so that we're making decisions for one unified health system and not for siloed pockets of our system. The last thing I'll mention, because I know we're running out on time, I can really talk a lot, is the concept I mentioned before to you of being the thread that weaves our system together. My team is very sick of hearing me talk about our space station that we're building. We have to be the logistics infrastructure for our state. We really are, on a national level, a leader in behavioral health care. I've had the privilege of going to, I think, 3 national events to learn from other experts across the United States that are in a similar role in their state or a more content-specific role. And I consistently am met with, how are you doing what you're doing? And those kudos go to the leaders that came before me, because it is amazing how advanced we are in Oklahoma. As you can imagine, I'm going to say that doesn't mean we stop. We don't ever stop. In healthcare, you don't stop, because that means that we're missing something. So having the opportunity as an organization to be the logistics infrastructure, and what I mean by that is, how do we, through technology, through payment models, through partnerships, how do we build hallways between our organizations that are meaningful and durable? The metaphor that's been in my head that the space station thing evolved from was a metaphor from a podcast that I listen to, frankly, when I'm feeling burnt out and need to reconnect to what we're doing. The metaphor is that the mental health system is like a house in which every room is designed by a different architect. That means it makes no sense whatsoever when you're trying to figure out where you need to go and how you're going to get to the next place. So if I'm lucky enough to get to one point of access in the system, I'm very likely not going to find that next access point. Oklahoma has most, not all, but most of the rooms across our state. So what we need to start focusing on is growing and integrating horizontally, connecting to one another. Doesn't matter if you're private or public or nonprofit, whatever you are. If you are serving the mental health and substance use community, we need to be woven together in a more meaningful way. If we do not do that, we will never reach any semblance of success for Oklahomans. So that is the fun stuff. That is the stuff that we get excited about. That is the reason that I put whiteboards everywhere I possibly could all over this building, so that when an idea hits, that we can start mapping it out and we can start making this make sense. The hallways are so complex, but we have everything we need in place to start putting them together. We have strong relationships with our sister agencies, with law enforcement, with criminal justice. We have so much opportunity, and that's what this administration is focused on. We can't get to the meaningful change if we don't know the problems that exist. So please take me up on the grace to allow us some time to start turning the ship, to identifying what's hiding in the corners, and partner with us to help us find what we need to find so that we can do what's right and we can build the space station, the house, whatever you want to call it, for Oklahomans. Because it makes no sense at all in my mind that we know exactly where to go if we're in a car accident and we have a broken leg, but we have no clue where to go if we're in a mental health crisis or we have a loved one that's in a mental health crisis. It's not fair. So that's what we're focused on trying to get to. And I think we'll take some questions.
Hi there, I'm Tom of Box 25. I was wondering, with this new vision, how does the challenges prison inmates have been facing with competency care, that pipeline, how does addressing some of those issues play into what you're talking about today?
So of course, as you can imagine, I'm going to give you the frustrating answer if I can't speak to any specifics, but what I can say is they are absolutely, every single human being we serve is an integral part of our new vision. There is no one that should be treated any differently, and everyone just deserves excellent care, period.
During Tuesday's contingency board meeting, you mentioned you were going to terminate Attorney General from representing mental health in the British class action lawsuit that you mentioned earlier. Have you made any progress on that? The Attorney General says he's not.
Absolutely. Prior to the contingency review board meeting, Commissioner Friesen did issue a termination letter to the Attorney General, and we do understand that he had issued a statement saying that she cannot fire him just as she cannot hire him. While we respect his statement, we certainly have a difference of opinion there. And unfortunately, at this time, that's all we can say regarding that matter.
So at this point, you think you have an attorney lined up? And when he steps down, you get somebody else ready to go?
We are working on that.
So whenever we talked on Tuesday, after the contingency review board meeting, you, I guess, pitched this press conference as an introduction of the new Oklahoma plan. So is the Oklahoma plan this, I guess, reset for your mission, vision, and I guess columns of the institution?
So that is something I'm going to let Dr. Beeman speak to specifically. And that was not the message I was trying to convey. It's my first media swarm, so.
No, you're good.
It's the Oklahoma plan is not the GE plan.
Yes,
Those are separate.
yes,
Okay.
thank you. So that is the name that Dr. Beeman has placed on some of the improvements that he's identified in even his short time that he's been here. So he obviously has a personal familiarity with our system. He has previously treated individuals in our system across multiple domains. And so that is a specific plan that we'll have to talk with him about how he would like to proceed. I think I said Tuesday that is something we need to circulate to internal stakeholders and partners that are involved in that process first. But again, in the spirit of transparency and putting my money where my mouth is, we certainly want to give that to you all as soon as we possibly can. But being mindful of the case that we're in right now, and as well as Dr. Beeman, because that is his baby, that is his plan. What I can say is that there are components, like I said on Tuesday, that have been going on for a while that we are making improvements on. There are multiple things that are in process and multiple things that we're trying to get teed up to be in process. So that is interwoven in our strategic plan as a whole to make sure that quality of care exists in that specific space.
Okay, so just so that I know that I understand this, the Oklahoma plan is about specific fixes to problems that already exist within the system. And the strategic plan is what you were talking about, which is more righting the ship and reevaluating mission statement, vision statements, and things like that.
Yeah, so the strategic plan is the big picture.
Okay.
And then all of our key strategies and initiatives, and we have all like down to the nitty-gritty what we internally want to accomplish, down to, I mentioned baseline, trying to kind of establish where we are. That plan, Dr. Beeman's Oklahoma plan, is work that needs to be done in general in the forensic space. And this is, and I told the Attorney General this months and months ago, this work would need to have been done anyways. It's the right thing to do. So lawsuit or not, and no matter where we go from this point, the work will continue to improve the quality of services. So that specific plan that he has developed and is developing is, again, a subcomponent, if you will, of the strategic plan.
Okay.
So while this litigation is underway, what's happening to services for inmates who need? Are there steps to try to improve that? Or are
Yes.
we waiting until this lawsuit is settled? What is happening?
We are continuing to provide as many services as we are legally able to provide at this point, and we'll continue monitoring the quality of those services and improving them where they need to be improved. And again, you should never hear from me, and if you do, be very concerned about me. You should never hear from me that we've reached our goal and we don't need to go any further. So no matter what domain of service, if we're talking criminal justice or crisis care or pediatrics, we should always be doing better. So everything that we have been within our legal parameters that we can execute on to improve care, we are doing. And we'll continue to do.
It's a wait list of 100 and some odd inmates who need competency care. Is that being addressed? Is that number going down, or is that?
I would lump
adding?
that into we are improving the quality of care and processes. Yes.
Yeah, I have a couple of questions for you, and the first is about the lawsuit still before we move on, I guess.
I had a feeling you guys would be interested in that.
Yeah, I mean, so there was a lot of coverage after the meeting, and you know, I'm curious about if you could spell out or maybe even spell out your legal team's interpretation of the consent decree in regards to the specific point you made that would only allow you to serve 2 out of 77 of the counties, especially because that's been called into question, the truthfulness of that statement by other people's on the plaintiff side.
Absolutely. So again, we're not going to talk about the specifics of the litigation itself, but I will tell you our interpretation of the document that we spent many months negotiating with both our counsel, the Attorney General, as well as the plaintiffs. So you all know that we have to provide competency restoration treatment per statute in the state of Oklahoma. That can happen a couple of different ways. The statute does allow us to provide it at the forensic center, or we can designate a willing and qualified entity to do so. We believe that that willing and qualified entity can be one of our CCBHC partners, and that can happen at the jail level. And that's what we implemented before Commissioner Friesen came on and joined us. And so we believe that the consent decree, actually we don't believe, we know the consent decree as it had been drafted originally had required us to cease the jail-based competency restoration program in all but 2 counties in Oklahoma. So Tulsa County and one other unidentified county that would be determined by the consultants. And so when she says we would have to cease treatment, that's what she's talking about. The consent decree would require us to stop in 77 counties and provide those services that again are critical in only 2 counties of our 77. That information, or that, I guess that provision, remained in the consent decree as it was entered last month, is what she was trying to articulate at the contingency review board.
Oh, excuse me, could I get your name down?
Christina Green, Assistant General Counsel for the department.
Okay, is that with a K or a C?
C.
Yeah, and so I hear you guys talking a lot about your through lines and this new initiative you have to make things better for the people that are in the department, for the people that you're serving. And I understand all of that and I respect it. But I'm curious if you could give me a few examples on a smaller scale of how plans that you have to make this possible, just to better conceptualize it or hear about how it's going to be affecting individuals.
So, thank you. And some of this might feel, I don't know, fluffy or rainbows and unicorns. It's not. As I mentioned earlier, every single person that has come before me in this role has had their own priorities. From where I stand or sit, our patient care has not been a priority in many, many, many years. I do not mean that disrespectfully. There are different phases, there are different needs in the community at different times. Our facilities have been neglected. There are no words for the environment of care we have allowed our patients and employees to operate within. We have a significant budget. We are blessed to have a significant budget that comes from multiple different sources. As I mentioned, being a good steward of those funds is a priority. We have sewage that has come through the wall in one of our crisis facilities for years and years and years. We have toilets that do not work in patient care areas so that patients have to line up like kindergartners and go to the bathroom. So when I say we are making things better, I say we are making things better because none of that should be tolerated, and we should not have any privilege to do anything else until we figure that out. So this is not rainbows and unicorns and let's all get along. It's quite the opposite. It is a reality check of what we're here to provide and who we are at our core, and that we've missed the mark. So we have designated individuals and designated teams that will be overseeing our operations and making sure that we have fidelity to everything we say we are going to do and that there's accountability in the organization. And so when I say every dollar, I mean every dollar, because there's no excuse for anyone that we know to be in a patient care area where there is sewage coming through a wall. So I take this very seriously, and I realize the lawsuit is timely and it is a big deal. But we have human lives that are at stake right now and people that need services. So when we talk about making things better, I mean, we have to act as quickly as we can to ensure that this work is done quickly and it is done well.
Yeah, if those issues are so blatantly clear to you at this time, why do you think they haven't been addressed previously?
I can't answer that. I mean, the only thing I can say is that, seriously, with all respect to former commissioners, because this job is so hard, that there are different priorities at different times. I know that there have been new initiatives in prevention services that have been, I mean, this department didn't come to be what it was overnight, right? This did not start as a priority for Oklahomans or for the nation. So the commissioners that have come before me have laid the groundwork for me to even have the ability to come in and look and see what's working and where do we have opportunity to improve. The things that are working well are large in part to those that have come before me. So they had different priorities, and what is the glaring need to me is what I just outlined to you.
You talk a little bit about the Donahue Mental Health Hospital, what's the status of that is, and then what is the funding gap? I think during the past session, you said about $78 million. I think that's still accurate, or is that number changed?
So out of respect for the leaders that we have not had a chance to sit down with, I'm not going to give you specifics on numbers. As soon as we can, I promise we will give that number. There still, of course, is a funding gap. We, over the summer, brought on board a construction management entity. Can I say their name, Shirley? It's public. Yeah, J.E. Dunn is who we're working with on that. And we are finally at a point where we have concrete plans, concrete numbers, concrete figures, and now it's a matter of essentially putting a venue in front of the decision makers at the legislature and in the executive branch to make sure that everybody's on the same page and so that we can get this done the right way. We are on track, and with 4 construction projects, I feel like I need to be an honorary contractor or architect at the end of this, and maybe a lawyer. But we are on track. And I am confident that we will get it done.
Is it winter 2026 was the original deadline? Is that still the deadline, or what?
I'm filtering through the 4 other. I had an OPCC meeting this morning, so you forgive me. Yeah, I think we're closer to 27. But when we come back with the figures for the funding gap, we will have a specific opening date as well.
Towards the end of your explanation of the strategic plan, we're talking about building hallways. You also mentioned that part of what you want to focus on right now is a baseline for Oklahoma, for care in Oklahoma. Would you say one of your goals in this baseline is for families or people having a mental health care crisis to know exactly where they need to go?
Absolutely. Yeah, I think that's a great way to put it. So there's going to be multiple different kind of key performance indicators that we look at to see what success looks like. But one of increased access to services is one of our key strategies. So that is certainly, again, has kind of become, well, yeah, duh, don't you want to increase access? But we're missing something, right? Because it's still not known to everyone where you go. And we have the blessing of having an enormous care network within our department and within our partners. And so there are a lot of bridges we need to build, and some of that's marketing, and some of that's, again, the hallway connectivity, some of it's the payer model, and a lot of partnerships. And we need to do a better job of getting into the minds of people and understanding what they need and how they really would access that information.
And I know you might not have a direct answer for this right now, but where should people go?
Yeah.
I've recently had the flu and ended up in the ER. And a large portion of the people who were in the ER were there because of a mental health crisis. And I assume that for a lot of people, if one of their family members is experiencing a mental health crisis, the ER is where they're going to go first.
Yep.
Is that still the case? Are y'all hoping to, I guess, whenever you say increase access to care, offer specific clinics?
Thanks. I'm really glad you asked that question. I'm sorry you had the flu. The ER is an appropriate place if there is a medical concern. So if you have ingested something, if you harmed yourself in some way and you need medical attention, or a person that you found needs medical attention, that is the place you should go, even if it came from a mental health crisis. If there is not a medical concern, you should go to one of our urgent recovery centers. And so there are approximately 30 across the state. You can go to our website and find them. And so when I say increasing access to service, you just heard me say we have 4 construction projects. There shouldn't be any more building, or not a lot more building, because we have grown so quickly in this space. It is what just happened right here. Like, oh, what is that? It's 24/7 access to mental health crisis care. And to previous administration's incredible credit, that growth happened so quickly and with such success. And so now we really get the easy part of that, because it's connecting the dots together and making sure people know that that service is available. And most of those are provided through our CCDHC partners.
Okay.
Over the last year, we've also seen 911 calls go down for mental health related needs, and all of those are being diverted to 988.
Yes.
So that's a really good positive thing that we've seen. We've been able to kind of support law enforcement in that way and make sure that people can get access through our crisis service line.
Yeah.
Are you guys gonna be implementing the 988 geo routing, new efforts that they have?
Yes. That was one of my biggest questions when I was even in my previous role, is how do we get that to be at least close to what the 911 system has, right? So I believe it's geofencing, so that we can, there's an accuracy, but it's not as specific as what the 911 system has. So certainly we have multiple leaders that are keeping a pulse on that over our crisis services and clinical programming. And we receive regular updates from the national organization that's over the 988 system. They've spoken at a few conferences that I've been to as well. So there's kind of a graded implementation for that, so they can work out any of the kinks, but very excited to see how that helps not only our 988 system, but also our first responders as well.
It's 4:55. We're going to take just a couple of more questions.
I had one. Apologies if this was addressed already. I just want to make sure I'm clear. Where do things stand with that settlement and lawsuit in light of the contingency review board? I'm just kind of looking for clarity on, like, in whose court is the ball right now in light of that decision? Like, where do things go from here, given the perhaps tension over the issue right now?
So the best way to, great question. Because that's something that I'm sure a lot of people wrestle with to try to understand that legal path. The thing to remember is that a consent decree is essentially a settlement. So if you have a lawsuit against your neighbor and you come to a settlement, that's what a consent decree is. If the consent decree or settlement doesn't go through for whatever reason, then you just proceed on with the case. And that's where we are at this point. We'll just, it's my understanding as of Tuesday that the contingency review board went ahead and voted no against this consent decree, and therefore the lawsuit itself will just proceed at this point.
One more building question. It's not related directly to mental health, but you all, mental health is partnered with the OU and the Behavioral Health Center. What's the status of that these days?
The building itself?
Yeah, where are we on that? Because it,
well, I think it's still progressing. I want to say it's 2026, but again, I'm not OU, but we have regular meetings with OU to make sure that we are sharing workforce in a meaningful way, because a lot of these facilities are going to open around the same time. And there's not a plethora of mental health clinicians and techs and nurses and psychiatrists that are just floating around. So we're trying to develop meaningful partnerships as to how we can partnerships to partner, imagine that, how we can connect and share resources where it makes sense. We're also discussing potential partnerships with OU in the ER space. So they have the beautiful pediatric emergency room and that beautiful facility that I think it is 2026 will open. But their adult ER, they have opportunity for us to potentially come in and embed one of our programmatic urgent recovery teams. So just the people that reside in our brick and mortar urgent recovery centers and try to provide that intervention when they show up to the emergency room. Really excited about the potential of that. Nothing's set in stone yet. As you can imagine, schedules are hard to coordinate with leaders of OU and us. But we've had some really great conversations about what that could look like. It's a matter of carving out enough space for that small team to come in and allow it to be therapeutic enough that we're not all on top of, in a person's face. But that could be an opportunity to start changing that shift from showing up to that physical emergency room when you truly are but you don't have a medical need and you're in a mental health crisis, that we can be that kind of connection point, and you have clinicians and professionals that are there to help you through that mental health crisis and stabilize you until you can get to one of our urgent recovery centers. So back to the innovation and evidence-based care, we're really trying to think out of the box as to how we can partner with our universities, with our health systems. But yes, we're supportive and love that OU is growing their pediatric service line. We know that we need it, and I'm hopeful that a lot of Oklahoma kids will get access to care they need.
So Christy, you say now that the lawsuit's going to proceed, there's no more, we're here, this Action Tuesday pretty much ended the consent decree.
Well, not necessarily. There are some court hearings.
I wish that were true.
Exactly. Yeah, there are some hearings that are set. There's some deadlines for objections by other parties, and then there will be a hearing on January 15th as well related to the consent decree itself. That's really all I'm going to say at this point, because we are in that whole does the AG represent us or not phase. So yes, for now, the contingency review board has voted against the consent decree, and we understand that the litigation itself will continue on to the merits of the case.
Does that mean Judge Frizzle can't pass it forward on the 15th?
Not necessarily.
Can you enumerate that?
I cannot.
How frustrating.
How frustrating.
That'll be our last question.
Yes, Jessica Fowl. I'm down with Lighthouse, one of the CCBHC partners.
Good to see you in person.
Yes. I was hoping that you could just share, you've mentioned how Oklahoma is one of the leaders. But one of the reasons we're one of the leaders is because we're one of the only states that all of the community mental health centers are CCBHC.
Yes.
So maybe you can just share like what that means, because it really truly is
Absolutely.
an amazing thing that Oklahoma's doing.
Yes, thank you for highlighting them. Thank you guys for being here.
Sure.
All of you. Yes, so that has been one of the primary reasons in conjunction with, and CCBHCs have a lot to do with that too, with the growth of our crisis system at 988 and our mobile crisis teams. Those are things that frankly, we kind of take for granted because we've had them for a little while, and that is an anomaly across other states. So the certified community behavioral health center model has changed the game in terms of community mental health primarily because of the payment structure, and it allows community mental health centers to function independently and be self-sustaining, which is unheard of in the mental health community in general. So it also allows for a community access model that has not historically been available in most states, that you are truly an integral part of your community and you are the provider to those in need in your specific area. So what we're looking at now, because of the wonderful growth we've had in our CCBHCs, is how do we support our CCBHCs kind of in phase 2, because every one of them did a fantastic job of growing, and that was the ask. That was one of the asks. One of the challenges is grow, meet the need of your community, show us that the data reflects you're meeting the need, and they did that successfully. And so now what we're trying to wrap our head around in partnership with the CCBHCs is, how do we support you in phase 2? What does that look like? Because there is such thing as overgrowing, right? And you will not be able to sustain if you grow too fast and too much. So we're trying to figure out, as an organization, as the department, what does meaningful support look like? And it might look different in different regions of the state. And then looking at partnerships. Now I'm going to forget what DCO stands for. Designated Collaborative, help me, organization? Sure. You guys can fact check me. But that is the model and the ability for our CCBHCs that have had so much success, and their ability to partner with smaller, more specialty nuanced clinics in the community. So instead of trying to compete against one another, this is a gross oversimplification, but instead of trying to compete with one another, it allows the opportunity for them to benefit from one another because CCBHCs have a lot of specifications and requirements or criteria they have to meet to even enter into that payment model. But we don't want to punish the smaller clinics for not being able to meet criteria for that. So it's a nice way to look at how we enter into a phase 2. And that doesn't make sense necessarily in every setting in every CCBHC, but where it does make sense, we're having the ability to start looking at some pilots and where we can make meaningful partnerships. And again, I don't know that I know of one state that is this advanced in the CCBHC process. And I have learned a lot about CCBHCs and still learn every single day about the complexities of the payment model and about the sustainability model because it is new even from a federal scale. So again, Oklahoma has led that charge in truly transforming what community mental health looks like. And that again highlights the opportunity for us not only to set the standard, but to be a meaningful partner in the community.
Thank you all for joining us today. If you guys have any further questions, feel free. I'm sure all of you have my email, phone number. If not, come find me. Thank you for joining us today on World Mental Health Day, and we hope you enjoy the rest of your day.
Thank you.